Thank you all for staying at this late hour for the end of the meeting. And what I would like to present to you is data on a prospective study that we're currently taking part in the UK. And I'd like to thank the previous speakers for setting the scene with regards to how we came about to use Prosigna. These are my disclosures. Today's talk I will discuss briefly about prognosis in early breast cancer. The guidelines that incorporate Prosigna into those, an overview of our European decision impact studies, the OPTIMA study in more detail, what is happening with Prosigna in the UK, and also to measure some other prospective studies that are currently being done or have been done. How did we get to this position that we are at the moment with regards to adjuvant chemotherapy? In the early 90s, the Oxford overview showed that there was a benefit of chemotherapy in patients with early breast cancer, and they could not find a group that did not benefit. And as a result, in the year 2000, not many years ago from now, the NIH convened a consensus conference in Washington that on adjuvant therapy in early breast cancer, and what they recommended was that most women with primary breast cancers larger than 1 centimeter of diameter, regardless of nodal, menopausal status or hormone receptor status, should be receiving chemotherapy. And as a result of that, for the next decade and a half, we had almost like a golden age of over-treatment of patients with early breast cancer, because clearly the majority of these patients were not benefiting from chemotherapy, but we did not have the tools to identify who they were. If we're looking at how those tools have come about, there are the conventional factors, such as tumor size, nodal status, grade, which have been used for a long time. We've already heard about the ER, PR, HER2, Ki67, and the limitations of Ki67. There have been attempts to integrate some of these factors into indices to define prognosis and who would then need chemotherapy. Nottingham Prognostic Index was the first one of those, and in the UK, the further away you go from Nottingham, the less use it is. There's Adjuvant Online, who, as many of you are familiar, is now Adjuvant Offline, and there is no, we do not know when it's likely to be used again. And in the UK, we have a program of Predict, which has it came about from population studies in the East Anglia region. This is widely used in the UK and is also used abroad as well. And a new version of Predict will come about soon. But really, the future is in genomic assays, and there are multiple of these assays which are available, and these are helping us to refine prognosis of patients and to make decisions on who would need chemotherapy. Also, importantly, avoiding overtreatment for many patients. The basis of the genomic testing comes from, as we said, in the early breast cancer trialist group in Oxford. They were not able to identify any patients who did not benefit from chemotherapy, but clearly the higher the risk of recurrence, the greater the absolute benefit will be, because the relative risk was the same. And most of the guidelines have come about use that cutoff point of if the risk of distant recurrence is less than 10%, the benefit of chemotherapy is unlikely to be sufficient to recommend it. So the genomic testings have been done in order to define populations with lower than 10% risk of distant recurrence. The Prosigna has now been available for several years, and it has now been incorporated into the guidelines of many national and international groups, ranging from St. Gallen, NCCN, ASCO, AGO, ESMO, and COMA guidelines. Prosigna has an expanding evidence base. We've already heard about the combined analysis of a TransAttack and ABCSG, showing the use and the utility of Prosigna in defining a group with low risk of recurrence. The Danish comprehensive cohort was important because it was a population cohort. And there has also been, as we've heard earlier, the biopsy determined and response to neoadjuvant chemotherapy. This is an expanding evidence base, and there is consistency in the results across the studies. And there is now also decision impact studies in a number of countries. And these, there's across different countries, from Spain, Germany, and France, more than 600 patients included. And what these show is that clinicians trust the results in order to omit chemotherapy in those patients who have a low scores. And there is also an American study, the decision study, but it has not reported as yet, but it's completed the accrual. So we go on to OPTIMA. OPTIMA was set up 5 years ago. A group of us in the UK were interested to the group of patients with ER-positive, HER2-negative disease. We've already seen that the genomic signatures are able to identify patients with node-negative disease who can be spared chemotherapy, and we wanted to look at a higher risk group of patients, those with node-positive disease and those with node-negative disease but larger than 3 centimeters. Before we proceeded to our main study, a feasibility study was performed. This was OPTIMA Prelim, which is now completed. And it was necessary to do this in order to establish the acceptability of the randomization, both for patients and for clinicians. We wanted to evaluate the performance of different tests within the UK system. And very importantly was the health economic analysis. The outline of the study was the control group was they received chemotherapy and endocrine therapy, as that would be standard. But the second group they received test-directed treatment. So on the basis of genomic tests, the patients, if they had a high-risk score, they received chemotherapy. If they had a low score, they did not receive chemotherapy. For the feasibility study, we made the randomization on the basis of oncotype, but we performed analysis of a number of other tests as well. It's important to point out that within OPTIMA, which is different from some other studies, the patients themselves do not know what their score is, because we felt that if the patients or the clinicians knew what the score was, it may influence what the other treatments will be. For example, their endocrine therapy may be different if the clinicians knew that those patients with node-positive disease were not receiving chemotherapy. So at the time of randomization, the clinicians are asked to say what chemotherapy schedule they're going to use, and they agree to all the other treatment to be the same, including endocrine treatment. So the patients were all over the age of 40, ER-positive, HER2-negative, and they were either node-negative tumors more than 3 centimeters or node-positive up to 9 positive lymph nodes. So these include high-risk patients, but the hypothesis is that although they're high risk for recurrence, they would not benefit from chemotherapy. And we did a number of assays, Oncotype, Prosigna, MammaPrint, IHC4, Aqua IHC4, and MammaTyper. So we had 5 different tests which gave us a score, and 3 which subclassified tumors. And if we look at the characteristics of the patients within this cohort, the majority of patients, 2/3, had nodes 1 to 3, about 15% had 4 to 9 lymph nodes, and about 20% node negative. And 40% had tumors more than 3 centimeters. And if we look at the data now for all these 300 patients who had the various genomic tests done, essentially what this shows is that all of the tests perform well, and they're able to classify patients into low and high risk. And for the tests will define patients within the low risk that seem to perform similarly. I think it's important to point out, though, that the tests do not, although on populations they perform similarly, individual patients, there is substantial discordance. And only about 40% of patients would be low risk for all the tests. And if we're looking by subclassification, 60% were all of them subclassified the same by all three tests. The health economics was important for us. The UK is very much a cost-effective health economy. And what we showed within our own analysis that the genomic tests are likely to be cost-effective and within the thresholds which are used by NICE, which is the government body which determines which treatments are used within the NHS. There is substantial uncertainty and has the need for more testing. And we also had a score for something which is defined as value of information, which was substantial for all tests, but it was felt to be highest for Prosigna. And our conclusions were each test has previously been validated against outcome. The OPTIPRelim is not able to identify which is the best test because you need to compare outcome for that, which we do not have as yet. But Prosigna was selected as the primary test for the main trial because it had the greatest value of information score, and it can also be done within the NHS. And at the time of the study, when we proceeded for the grant application, Oncotype DX was not financially viable, but it would be now with the changes in cost. And further research, it was felt to be worthwhile, and importantly, accrual to the OPTIMA study was feasible. And so the main study, which has now started recruiting for several months, the patients are exactly the same as went into the feasibility study. The outline is the same, but what we're using is Prosigna instead of Oncotype. And so the patients, high score, which is a cutoff of 60, they will have chemotherapy, lower score, endocrine therapy. And what we're looking for is non-inferiority of a difference of 3%. And we're looking for 4,500 patients to be accrued over 4 years. At the moment, we've randomized we previously randomized 412 patients to OPTIMA Prelim. 290 patients have been randomized so far in the main study. We have 76 sites open, and we expect 100 to 120 sites in the UK to be open. Norway will be taking part in the study, and they will start recruiting in the next 2 or 3 months. Canada considering it. We would like more countries to take part. This is my email address. Anybody who would like to discuss the study more, wants to think about it in their own countries, please get in touch with me, either by email or we can discuss afterwards at the reception. And in the UK, Prosigna is being carried out for the study at the University College Hospital. And we have a turnaround time now of mean of 12 days. And the way that this is achieved is that we have a run on Wednesdays. So as long as the sample is delivered to University College by Wednesday, there will be a result by the end of the week. If it arrives by after Wednesday, the result will be available by the end of the following week. So we're essentially having either 7 days or 14 days turnaround. And so the testing is so far is performing well with almost no failures of the test. In the UK, outside the trials, there is a test available through the Royal Marsden Hospital for patients with private insurance, and there will soon be another machine at the University College Hospital for routine testing. And NICE are currently looking at the genomic assays, including the use of Prosigna, and the final guidance is expected in June 2018. And some of the draft guidance is available on their website. So of trials which that have been done and we're waiting for results, TAILOR-X, as many of you know, is looking at for the oncotype for the intermediate group where the patients were randomized to plus or minus chemotherapy, and I understand there may be a result for this at ASCO or the latest San Antonio this year. And in the States, a study in node-positive patients was performed, a responder, and within that study, they looked at 1 to 3 lymph nodes. And the other difference as with our study was that the patients and the clinicians knew what the score of the patient was. Expert is an Australian study utilizing Prosigna to determine patients over the age of 50 with T1 and node tumors, ER positive, HER2 negative, whether you can avoid chemotherapy, avoid radiotherapy for these patients after breast-conserving surgery. So it's really showing the expansion of the utility of Prosigna. And so to conclude my presentation, we feel that the OPTIMA design is a gold standard approach to test the clinical utility and the cost effectiveness of these assays. Prosigna was chosen to test within the OPTIMA main trial. We feel that it will provide level 1 evidence for the benefit of test-directed treatment. And the population of OPTIMA is high risk than some of the other trials, and is going to generate data in the patients where the utility of multi-parameter assays is likely to be most needed, which is the patients who are currently receiving chemotherapy. And I'd like to thank all the people involved in the OPTIMA team, and particularly my good friend and colleague, Dr. Stein, who is in the audience and will be sharing a beer later. And without his support in this study, I don't think will ever have been done.